Good morning, everyone. My name is Michelle Amsterdam. I'm a therapist and a mental health consultant, and the founder of the Art of Wellbeing, Counseling, and Consulting Practice in Guyana. Today, it is my privilege to introduce the speaker for this session, Dr. Lupo Geronazzo-Alman, who will be presenting on machine learning, causal structural discovery, and predictive modeling study of psychiatric disorders in children of first responders. Dr. Lupo Geronazzo-Alman is Assistant Professor of Clinical Medical Psychology in Psychiatry at Columbia University. His research interests include identifying and characterizing the early indicators of psychiatric vulnerability and biological and behavioral correlates, including premorbid markers of vulnerability and trajectory of mental health. He has conducted highly innovative research at the interface of psychiatry, epidemiology, and advanced data science, including machine learning and computational causal discovery methods to better describe psychiatric phenomena and their etiologies. Dr. Geronazzo-Alman is currently an MPI of the NIOSH-funded study, RDoC Domains Underlying Emotional Health and Trajectories of Psychopathology in Families of WTC First Responders and Evacuees, a genome-wide G/E study. MPIs Dr. Hoven and Geronazzo-Alman. I now hand you over to Dr. Lupo Geronazzo-Alman.
Hi, good morning. Thank you very much for this introduction. Thank you for inviting me to this conference. As was just said, my talk is about a machine learning causal structure discovery study and predictive modeling study of psychiatric disorders in children of first responders. However, I think that I'm talking about this because I think it's the methods that were used are potentially very relevant for suicide prevention and to study suicide. So just a brief introduction. As you probably know, there has been extensive literature that has been published on several risk factors that are associated with psychiatric disorders, from biological risk factors, cognitive risk factors, environmental risk factors, all sort of risk factors. However, despite all of this literature, the limitations that are intrinsic in traditional theoretically driven statistical methods like correlational analysis, regression analysis, etc., have hindered the development of models for the description of the causal structure of risk factors underlying psychiatric disorders and models for the accurate prediction of psychiatric disorders. So unlike traditional statistical methods, like, again, for example, regression analysis, machine learning which is a subfield of artificial intelligence, is a data-driven method. So it's not theoretically driven, it's data-driven. And it's a method that seeks to learn the optimal model to characterize the data according to whatever the task at hand is, according to whatever the goal of the study is, such as, for example, understanding the causal structure of risk factors underlying psychiatric disorders, or building a model for the accurate prediction of psychiatric disorder. And an important application of machine learning is to data sets that were previously analyzed with traditional statistical approaches. And this is particularly relevant for studies that have a large amount of data, but a relatively small sample. So in these data sets, the data-driven machine learning approach can reanalyze the data and generate new knowledge, for example, on what I just said, on the causal structure of risk factors underlying psychiatric disorders, and generate new knowledge on how to best predict psychiatric disorders. I refer to these two goals, let's say, as causal structure discovery analysis and predictive modeling. And this is exactly what we have done. Using machine learning, we reanalyzed a relatively small sample of parents and children. It's a sample that comes from Israel, and it's part of the Children of First Responder study, which was a two-site study conducted in New York City and in Israel. So we reanalyzed the data from the Israeli sample. And the Children of First Responder study is the only study that was designed to understand the relationship between parental exposure to work-related events like policemen that are shot or firefighters that have to go into a fire, like, you know, exposure to dangerous work-related situations, work-related events. So understand the relationship between occupational exposure in the parents and children's psychopathology. And this is often referred to in the literature as secondary traumatization. So the families of first responders and controls had almost all the time 2 parents and a child aged 9 to 16. And the data set that we used for this particular study, it was a little bit less than 200 families. Several variables were measured. This is just an overview of the variables that were used for this study. So there are variables that were measured in mothers and fathers, like the occupation, such as they ever worked as first responders, they ever worked in the military, etc. Of course, occupational exposure was measured. Psychiatric disorders in the parents, like PTSD, psychological distress, and major depression. And then we use variables that were assessed in the children, such as report of maternal and parental occupational exposure. So how much does the child know about parental occupational exposure? The children's own exposure, such as, you know, the children exposure to traumatic events, stressful events, etc. Then family level variables. So children had to report on the quality of the attachment to their parents, the family satisfaction, parent-child relationship, etc. And we created like a variable that indicates negative family, like a negative family environment, basically. So negative family satisfaction, negative parent-child relationship, etc. And then obviously psychiatric outcomes. The good thing about this study is that many psychiatric outcomes were measured, as you can see. So there are trauma-related psychiatric outcomes, there's anxiety disorders, mood disorders, so-called externalizing disorders like oppositional defiant disorder and conduct disorder, and functional impairment was also measured. So this is just a brief introduction to the first aim of the study. What you usually read in most papers, in most non-experimental psychiatric papers, is that a variable is associated with another variable. So variable A is associated with variable B, right? That's what you read in most studies, like a risk factor is associated with a certain outcome. But when 2 variables are simply associated with each other, for example, through a regression analysis or a correlational analysis, you don't really know the cause of the direction of the association. You don't know if A causes B, you don't know if B causes A, and you don't know if there's a third variable that you haven't considered that is causing both A and B, and that's why you find an association. That's why you find a correlation. So an association really doesn't tell you anything about the direction of the association. So it doesn't tell you anything about the causation. As I said, this data set was previously analyzed with regression analysis. So regression analysis didn't tell us anything about the causal structure of the variables in the data set. So it didn't tell us anything about the direction of the association. All we knew was that some variables were associated with other variables without knowing, which variable caused which other variable. So since we're talking about causation, this is just an informal definition of causation. Causation is defined as a relationship between 2 variables, like variable A and variable B, such as that manipulating A, meaning changing A, will lead to changes in B, relative to when A is not changed, relative to when A is not manipulated. You can find a more formal definition of causation in these papers that I reported at the end in the conferences. So, and this is also another situation. If there is no direct relationship between A and B, but there's a third variable that causes both A and B, changing A will not lead to changes in B, even though you find an association. In this situation, also changing A will not change B because it's B that is causing A. So this is really the only situation in which changing A will change B. Again, when you simply have a regression analysis and a measure of the association, you don't really know what is going on. So it's important to remember that even though a risk factor may be associated with a disease, it does not necessarily mean that if I change that risk factor, I will change the likelihood of developing the disease. So a causal factor is instead a factor that if I manage to change that factor, will change the likelihood of an outcome. So intervening on a non-causal factor will not change the outcome. So it's very important for psychiatric research, actually for any sort of health-related research, to understand if two variables are not simply associated with each other, but in fact, if they're causally associated with each other. So this is just an example of what we found in the previous paper. This is a regression analysis. Let's just ignore the first part for now. What you typically see, and this is from the paper that I was mentioning before that used regression analysis. You see the outcomes on top, such as post-traumatic stress, generalized anxiety, separation anxiety, etc. You have your predictors, your independent variables on the left, and then you have the measures of association. So you have the estimate from the logistic regression, and you have the significance level, etc. So you know which independent variable is associated with which outcome. I will use as an example in the following slide the following variables. As you can see, the maternal CIHQ score is simply a variable that indicates the severity of maternal occupational exposure. So as you can see, this variable is associated with several outcomes. I will use as an example also maternal psychopathology. The case score, K10, is a measure of psychological distress. So let's say maternal psychopathology is also associated with some of the outcomes. Also maternal depression, the BDI is the back depression inventory. And then I will use as an example also negative parent-child relationship, which is pretty much associated with the same outcomes that these other variables are associated with. So we have a situation in which maternal occupational exposure, maternal psychopathology, and negative parent-child relationship are associated pretty much with the same outcomes. So as I just said, maternal occupation was associated with several psychiatric outcomes. Maternal psychopathology and negative parent-child relationship were also associated with the same outcomes. So the question is, what is the causal network that explains this association? What are the causal relationships? Because we have different scenarios. Again, when we only have a measure of association, it could be this scenario. So maternal occupational exposure could cause maternal psychopathology, which could cause negative parent-child relationship, and then cause children's psychiatric outcomes. If this was the actual scenario, intervening on maternal psychopathology and negative parent-child relationship would have a positive effect on children's psychiatric outcomes because of the causal relationships between these variables. But again, with associations, we don't know, because it could be this scenario. So these three risk factors could be independently associated with the outcomes. So if this was true, intervening on maternal psychopathology and negative parent-child relationship would have a positive effect on children's psychiatric outcomes, but it might not necessarily help children with higher level of maternal occupational exposure. Or it could be other scenarios, it could be that maternal occupational exposure is causally related with children's psychiatric outcomes, and children that have more psychiatric outcomes also are more likely to have negative parent-child relationship. And if there's a negative parent-child relationship in the family, then there's a higher likelihood of maternal psychopathology. Mothers could be more depressed, could be more distressed because of this negative parent-child relationship. Or it could be a completely different scenario, like a measured or unmeasured confounder that was not included in the analysis could cause both variables, which then cause maternal psychopathology and negative parent-child relationship. So in these two scenarios, scenario 3 and scenario 4, as you can see, intervening on intervening on maternal psychopathology will have absolutely no effect on children's psychiatric outcomes, because maternal psychopathology in these examples is downstream. It's like it's a consequence of other variables. It's not causally related to children's psychiatric outcomes. The point here is that if you simply have a measure of associations between these variables, you don't really know what's going on. You don't know if it's scenario 1, scenario 2, scenario 3, scenario 4, or maybe other scenarios that you even haven't considered. So you don't know what to do in terms of interventions. So as I said, the causal structure of variables in the data sets could not be determined by the regression analysis that we used in the previous study. So the first aim of the study was to do a causal structure discovery analysis, and was to examine whether parental occupational exposure to traumatic events is causally associated to the children's psychiatric outcomes. And if it's associated, we wanted to understand if it's directly linked to the outcomes or if there are causal mediators that that basically that mediate between these two variables. An example of causal mediators are some of the variables that I just mentioned. So parental psychopathology, the children knowledge or children report of parental occupational exposure, variables measuring the family environment, such as negative parent-child relationship, family satisfaction, etc. And then the children's own exposure to life events. The method that we use is a novel machine learning algorithm for causal structure discovery called greedy fast causal inference algorithm. This is a very novel algorithm. The first report was in 2016, but it has been used in psychiatry only very recently, actually only in 2 papers in adults. The most important thing about the greedy fast causal inference algorithm is that it generates something called a partial ancestral graph. A partial ancestral graph is just a fancy name for a figure, for a graph that describes the causal relationships among the variables. But partial ancestral graphs have 2 very important properties. They give information not only on the direction of the association, so not only on they give information not only on causation, which variable is causally linked to which other variable, and this is something that few other algorithms do. But unlike any other algorithm, the greedy fast causal inference algorithm can take into account the possible influence of unmeasured variables. And this is very important for psychiatric research because it's very unlikely to think that you measured and included in your model all the potential relevant variables out there. So if you study major depression, for example, or suicide, it's even if your study is very large in terms of data that you collect, it's very unlikely that you really measured all the potential variables that are relevant, all the variables that are potentially relevant to understand suicide or major depression. So the greedy fast causal inference algorithm can instead understand if unmeasured variables are involved in explaining the relationship between some of the variables that you actually collected. And this is something that only this algorithm can do. The second aim was to actually estimate the effects of intervening on variables and understand what intervening on some variables like potential treatment targets, understand how that would affect the outcomes. So there are several steps to identify potential intervention targets, because that's always the main goal of research should be, okay, we have these nice findings with machine learning or whatever you do, but how do we translate these findings into something that can actually, make people's lives better, can improve their mental health. So this is just a summary of some of the steps that are involved in identifying targets for outcomes, such as suicide, for example. You first have to learn the causal structure of variables underlying the outcomes. This is what we do in aim 1 with the greedy fast causal inference algorithm. However, the greedy fast causal inference algorithm describes qualitatively the causal relationships among variables. And this is very important information, but is insufficient to estimate the effects of intervention on a potential target variable causally linked to the outcome of interest. So the second step is really to, once you have identified the causal structure of risk factors, the second step is to estimate the effect size associated with each variable along the causal path. So basically, the next step is to measure the effect size of each association in your network of variables. And for that, we use structural equation modeling. The third step is to identify by expert knowledge. So, psychiatrists, psychologists, social workers, whatever, can get the results, can look at the results, can examine the results, and identify which variables that are causally linked to an outcome are potential good treatment targets. And we'll talk about that. We'll talk about that later. So, okay, so the second aim of the study was to, estimate the effects of intervening on some of the variables in the causal network. So the second aim was to identify, by manipulatable variables, I mean variables that can be changed, variables on which you can intervene. So variables that can be manipulated with an intervention, for example. So the second aim was to identify manipulatable variables, meaning potential targets for intervention along the causal pathways from parental occupational exposure to the children's outcomes. And it was also, the second aim was also to estimate the expected change in the outcomes resulting from intervening on these variables. To do that, we applied, as I said, structural equation modeling. Again, it's important to keep in mind that causal structure discovery analysis is a way to describe the causal relationships from a qualitative point of view. Structural equation modeling is a good way to use the causal structure that was identified with the machine learning algorithm that I just described and estimate the quantitative relationships among variables in the partial ancestral graph generated by the algorithm. But we'll see examples later, so it should be clearer. So an effect size, this is a simple definition, for any directed edge of the type A causes B. So it's a direct edge because there's a direct relationship between A and B. The effect size calculated by structural equation modeling represents the expected unit change in B by unit change in A. So if the effect size of the relationship A causes B was 0.5, this means that a 1 unit increase in A would correspond to a half unit increase in B, or a 1 unit decrease in A would correspond to a half a unit decrease in B. Okay, we can. Okay, so this is the partial ancestor graph that was generated by the greedy fast causal inference algorithm in the in this data set. I know there's a lot going on here, but there's so different colors mean are here to represent different variables. So in green, I reported variables measuring parental occupational exposure. In yellow is variables measuring parental occupation. So if they were first responders or if they worked in the emergency room, etc. In blue, blue is for variables measuring parental psychopathology, such as PTSD. The K10 is psychological distress. BDI is major depression. In pink, I reported the children own exposure to traumatic events. In this gray is for children report of parental occupational exposure. And in orange is the children's psychiatric outcome. So this relationship and these arrows are the causal relationships that were identified with the machine learning algorithm that I just described. The numbers that you see next to each edge, meaning next to each arrow, are the effect sizes calculated through structural equation modeling. So what you see here is really the main output, which is basically a description of each causal relationships between every variable in the data sets and the effect size of each relationship. I know there's a lot going on here, but I just wanted to point out 2 things for now. First of all, as you can see, all of the arrows connecting parental occupational exposure variables to the outcomes are green arrows. So in the output of this machine learning algorithm, a green arrow has a particular meaning. So a green arrow connecting 2 variables such as X and Y, so X causing Y, implies that all of the following statements are true. X is a direct cause of Y. X and Y are not confounded. Remember what I said before about the ability of this machine learning algorithm to say if the relationship is confounded. And for sure, Y is not a cause of X. So it's a good situation to have a graph like this one in which most arrows are green arrows, because you know that the relationships are not confounded. So all arrows connecting parental occupational exposure variables to the outcomes are not confounded, are direct arrows. And actually most relationships in this graph are not confounded. Some of the relationships are confounded, as you can see these blue arrows. It means that this causal relationship might be explained by a variable that you haven't considered. Something else that I want to point out now is that, remember what I said before, the example I used before about negative parent-child relationship and the association between maternal exposure to work-related traumatic events and childhood psychopathology. We didn't really know the direction of the association. So in the previous study, we said that negative parent-child relationship, negative family satisfaction were associated with the outcomes. But again, we didn't know the direction of the association. Although we suggested that, you know, negative parent-child relationship, negative family satisfaction, negative monitoring and attachment could be potential targets for intervention. Again, but we didn't know the direction of causation. So it was really just a supposition. It was just a suggestion. What you see here is that these variables are actually consequences rather than causes of children's psychiatric outcomes. There is only a very modest, a very small relationship between negative family satisfaction and children conduct disorder. So negative family satisfaction being a cause of children conduct disorder, even though the effect size is very small. But for all other disorders, these variables that measure the negative family environment are consequences rather than causes of the disorder. So as you can see, they're all downstream compared to children's psychiatric outcomes. So what these results suggest is that these variables are not good targets for intervention because they're not causally associated with the outcomes, but instead they're consequences of the outcomes. Again, this is just, you know, in these data sets, and this is a cross-sectional study. So if you have a longitudinal study or other data sets, you know, things may change. But what this result suggests is that these variables are not good treatment targets. So this is just an example of the difference between machine learning, causal structure discovery analysis. It actually tells you what variable is associated with what other variables, and if a variable could be a potential good treatment target because it's causally associated with an outcome. And instead, association analysis, in which, you know, you absolutely have no idea about what's going on in terms of causation. The other type of information that you can gather from this type of analysis is what are the different causal pathways that connect your main variable of interest to the outcome. So in this case, we have, I don't think we have to go into the details of all of these pathways, but this is an example of a direct pathways that connect parental occupational exposure variables to the outcomes. This is an example of an indirect pathway. So this is the variable measuring parental occupational exposure. These are the outcomes. It's an indirect pathway because there are other variables that are in between these, the main risk factor of interest and the outcome. So in this case, their indirect pathways go through the children's own exposure to traumatic events. Another example of an indirect pathway is a pathway that connects parental occupational exposure to the outcomes, going through parental psychopathology. This is another example of an indirect path. This is actually you know, important. Not every path is shown here, but I just want to point out that there are some outcomes like children's agoraphobia, children oppositional defiant disorder, that are connected to the rest of the network only through other children's psychiatric disorders. So for example, oppositional defiant disorder and agoraphobia is connected to the rest of the network only through separation anxiety, and are connected to the rest of the networks only through separation anxiety and major depression. This type of information is very important for interventions, and we'll see an example later. So what you see here is that, for example, there is no psychiatric disorder that is causally linked to PTSD. So PTSD is sort of like an initiator of other psychiatric disorders. It's causally linked to other psychiatric disorders. It's not caused by any other disorder. What you see is that major depression is the disorder that is connected to the largest number of other disorders. So major depression is causally, it's a cause of generalized anxiety, of agoraphobia, of oppositional defiant disorder. So major depression is actually sort of like a bridge disorder that connects internalizing disorders and externalizing disorders. So externalizing and internalizing dimensions of psychopathology. Again, when you want to plan an intervention, when you want to understand what's going on in your data sets, like in terms of causality, this type of information is very important. So let's see some examples now of what do we do with these results. How can we use these results? So as I said before, one of the causal pathways linking parental occupational exposure to the children's outcome was an indirect pathway that was going through parental psychopathology, such as PTSD, post-traumatic stress, and psychological distress. So these are, the variables in the network. Here we just focus on parental PTSD and the outcomes and the other variables that are along this causal pathway. So how do we use causal structure discovery analysis and results from structural equation modeling to understand what could be the effect of an intervention, and what do we have to think about when we plan an intervention? So the first thing we have to consider when we plan an intervention based on these results is, what is our setting? So is it a workplace setting? Is it the private office of a mental health professional? Is it a school setting? So these are children of first responders, right? So the first example that I want to use is a setting in a workplace. So a workplace could be, I live in New York City, so it could be the New York City Police Department or the New York City Fire Department. It's an association of first responders, right, who is interested in preventing psychiatric outcomes in children of first responders. So this is an example in a workplace setting. So the first thing you have to consider is the setting of your intervention. Then you have to consider three main factors. You have to identify variables that are manipulatable, so meaning variables on which you can intervene. Variables that have to be also easily measurable, because this will will make your intervention or your study will make it cost effective and also effective in terms of time. If you need brain imaging and genetics and stuff like that to prevent an outcome, it could be interesting in some fields and it could be interesting for some applications, but in terms of prevention on a large scale, it's less efficient because it's costly, it's time consuming, etc. And obviously, the variables that you select for interventions have to be causally linked to the outcomes, right? That's probably one of the main points. So in a workplace setting, workplace settings could actually measure parental occupational exposure to traumatic events, but this is not a very manipulatable variable. It's not a variable you can easily intervene on, unless you come up with an intervention that would decrease parental occupational exposure. There might be something out there, but this is really not so much my field. So in this example, I'm going to use parental post-traumatic stress as an ideal target for an intervention in a workplace setting. Why? Because post-traumatic stress, parental post-traumatic stress, is manipulatable. Obviously, meaning that there are a lot of interventions like psychotherapy or like different kinds of psychotherapy that can with which you can intervene on post-traumatic stress. It's easily measurable. In this case, for example, all you need is a tool for self-report of PTSD symptoms, and is causally linked to the outcome. So post-traumatic stress sort of like checks all the boxes. Here we simulate an intervention on parental PTSD. The levels of parental PTSD in the sample were not that high. So the score of the measure that was used to measure PTSD goes from 17 to 85. So the minimum score is 17. Here we simulate an intervention that would bring everybody to every parent's PTSD level to the minimum level. So such an intervention would correspond to an 8.6 points reduction in maternal lifetime PTSD scores, a 9.3 units or a 9.3 points reduction in paternal lifetime PTSD score, and an 8.6 unit reduction in a current paternal PTSD score. So this is your unit change in your main risk factor of interest. You can simulate whatever you want, so you can change these numbers. You can simulate other types of intervention. This is really just an example. So this is the expected reduction in PTSD scores if we had to do like such a good intervention that everybody's PTSD would basically go down to 0, which is it's possible in this sample given the fact that PTSD levels were not that high. So this is your unit change, and then what you do is you multiply this unit change in your in your risk factor of interest by the effect size that was calculated through structural equation modeling. So for example, an 8.6 change in maternal lifetime PTSD score multiplied by 0.27 would correspond to almost 2 symptom decrease in children PTSD. Children PTSD score were influenced also by this causal pathway, which would correspond to a 0.65 unit decrease in PTSD. So the sum of the two of them gives you an almost 3 units change, meaning 3 symptoms, decrease of 3 symptoms in PTSD, just as an idea, which is a lot. And you basically then follow the same approach to calculate what would happen going down these other causal pathways. So you take this unit change in PTSD, 2.97, and you multiply it by the effect size calculated with structural equation modeling that connects these 2 variables. And you do the same for all other paths. And then you have the final estimate of what would be the expected unit change in the outcomes if you had to intervene on parental PTSD. So such an intervention would have a pretty substantial effect on PTSD, on major depression, on generalized anxiety, on separation anxiety, while the effect on oppositional defense disorder, agoraphobia, panic disorder, and conduct disorder would be more marginal. Again, this is really just an example. You can use any number here. You can simulate any number. So this is another example. Remember how I said that another indirect path linking parental occupational exposure variable to children's psychopathology was going through other children's psychiatric disorders. I showed this graph before. So this is simulating an intervention in a school setting. So again, in a school setting, different setting, it's unlikely, it's very unrealistic that in a school setting you could measure parental psychopathology, parental exposure to work-related traumatic events. But in schools, you could easily measure the children's psychopathology. So based on the findings from the causal structure discovery analysis and from structural equation modeling, we simulated an intervention on major depression. Major depression is a good target for intervention because it's causally linked to many other outcomes, is easily measurable, and is manipulatable. Again, there's a lot of interventions out there that can decrease symptoms of major depression. And the approach that we follow for this simulation is very much the same. We simulated an intervention that would bring depression scores to 0. And then we followed the same approach. We multiplied this unit decrease in your main variable of interest, in this case, major depression. You multiply by the effect size calculated with structural equation modeling, and you have the estimated unit change in your outcomes. So an intervention on major depression would not only obviously decrease major depression, but it would have significant effects also on generalized anxiety disorders, oppositional defense disorder, functional impairment, and well, yes, the effect on other disorders would be more marginal. Again, just to keep in mind that these are really just examples. So based on your population, based on your sample, based on your settings, you can simulate other types of intervention. So you can you can change the number here. This is another example of how to use structural equation modeling. Again, there's a lot going on here, but you can actually calculate the final causal effect of a variable of interest on your outcomes. So here we simulated a 1 unit increase in this variable measuring parental occupational exposure. A 1 unit increase is pretty significant because the average score for this index of parental occupational exposure was, let's say, 6. So 1 unit increase from 6 is a pretty significant increase. And this is really just an example. You can simulate, again, you can simulate whatever you want. The approach is the same. You multiply this unit increase in your main predictor of interest by the effect size calculated with structural equation modeling. You do this for every causal path, and this gives you an estimate of the final causal effect on each outcome of a 1 unit increase in this variable. Obviously, to do this type of calculation and this type of reasoning, you need to know the causal structure of your data sets, and you need to know the effect size of each relationship in this network. I think we can move on to the third and final aim of the study, which was the predictive modeling. So we talked about causal structure discovery. Now, which it's great to understand, as I hope you saw, it's great to understand how the variables that you have are causally related to each other and causally related to the outcome of interest. Causal structure discovery analysis is also very effective, as you saw, to understand the effect of an intervention, to identify intervention targets, and to estimate, and as I said, yes, to estimate the effect of such an intervention on your outcomes. Sort of like a related but separate point is, how can we predict the outcomes? So the first question was, what are the causes of the outcomes and what are the good treatment targets? Second question is, how do we predict a certain outcome? So how do we predict psychiatric disorders in children of first responders, or in case of suicide, how do we best predict suicide in our population? So this is just an introduction on, and maybe we don't have to go into the details here, but the main difference between traditional statistical analysis and predictive modeling. Traditional statistical analysis, like regression analysis, are theoretically driven. You have to usually select a small number of variables, and their main concern is with the p-level. So all you hear is the p-level. Is the p-level significant? Is it not significant? Is it marginally significant? It seems like that's all you care about with regression analysis. You often ignore even the effect of the association, like the magnitude of the association, like the estimate or the odd rate or the odds ratio. So all you obsess with is the p-value. The p-value has a lot of problems. The emphasis that is placed on p-values has a lot of problems. It creates overfitting. It creates problem with generalizability of findings, with replication of findings. For example, in large sample, statistically significant results, this is very important, can be found even when the effect size of the main statistic of interest, such as a regression coefficient, is negligible. So even when you have a very small difference between two groups, in very large samples, you can find a significant p-value, even though the difference between groups is minimal and is negligible and is not clinically meaningful. Unlike traditional statistical approaches, machine learning, as I said before, is data-driven, and it doesn't care about p-value. Machine learning is concerned with finding the best model to characterize the data according to whatever you want to do. So the best model to explain the causal structure of risk factors in your data sets, as we saw before, or the best model to predict your outcomes, such as psychiatric disorders in children of adolescents. Something important to consider is that, as you saw before, we have about 50 variables. It's actually 46 variables. It's not a lot of variables, but it's still it's a good number of variables. So when you build a predictive model, you can use all of these variables, but most likely not all of these variables will be necessary to best predict your model. So what you do in predictive modeling is something called feature selection. Feature selection does what the term says. So it selects the best and most predictive set of features to predict your outcomes. So with feature selection, you're really aiming at obtaining the minimal set of variables that give you the maximum amount of predictive information regarding your outcomes. The identification of a smaller set of predictive features is very important, because again, if you want to have an efficient predictive model, if you can achieve the same predictive accuracy with a smaller set of variables, you're in a much better situation, because your predictive model becomes more cost effective, and it will be easier to actually then be deployed applied to a certain population. So the third aim was to develop effective models for the prediction of psychiatric outcomes in children of parents exposed to work-related traumatic events, such as children of first responders. I'm not sure we need to go into the details of these methods. As a prediction model or so-called classifier, we use random forest. The repeated and full cross-validation is a typical protocol to estimate the predictive performance of your predictive model and to estimate the generalizability of your findings. But again, you can forget this. The predictive performance, this is maybe something important. was measured by the area under the receiver operating characteristic curve. You may have seen this before, is the AUC. AUC values range from 0 to 1. When AUC values are close to 1, it means that your model is very good at predicting what it has to predict. For feature selection, we use a pretty novel machine learning algorithm for feature selection called Heighton PC. Again, this is something that they reported here in case you're interested reading something more about it. So what did we do? As I said, we have 46 variables, as you can see here at the top. In a first set of predictive modeling, we use all 46 features. These are your outcomes on the left. And this is, models without feature selection and with feature selection. So when we started to build our predictive models using all 46 features, the predictive accuracy measured by the area under the curve was very good. As you can see, as I said, the closer to 1, the better your predictive performance is. So as you can see, the numbers here are very high. The main point here is that, let's just use PTSD as an example. The predictive accuracy of our model that used all 46 risk factors was very good without feature selection. But you need 46 variables to reach this level of predictive accuracy. When we applied feature selection, you can pretty much reach the same level of predictive accuracy. As you can see, 88 is not very far, it's not very different from 90. But your model is much more parsimonious because the number of features retained after feature selection was only 10. So with 10 variables, you can reach the same level of predictive accuracy that you reach with 46 variables. And this is the same for all other outcomes considered. So feature selection is a very powerful tool to identify, as I said before, the most predictive set of variables to predict your outcome. For generalized anxiety disorder, the situation was the same. When we don't apply feature selection, you do have a good predictive performance, but you need 46 variables. When we applied feature selection, you pretty much have the same predictive performance, using generalized anxiety disorder as an example now, but you need to measure only 5 variables. So this is something very important to keep in mind. The problem with this predictive modeling is that a lot of the variables that were retained after feature selection were other children's psychiatric outcomes. So this what I mean is that to predict for post-traumatic stress disorder, for example, probably, I don't remember now, but I think you needed other disorders in the model to predict post-traumatic stress disorder, and the similar situation for other disorders. So you do reach a good predictive accuracy, but then the question is like, what do I do with these models? Like, if I need to measure other psychiatric disorders to predict another psychiatric disorder, then I might as well just measure the psychiatric disorder I want to predict. So for example, if I need to measure generalized anxiety and separation anxiety to predict PTSD, I might as well just measure PTSD. So what did we do then? Since, keep in mind that these are children of first responders, we said, why don't we try to build predictive models using only variables that can be measured at the parental level? So again, think about a situation, I think about a workplace setting, like the New York City Police Department, the New York City Fire Department. They're interested in predicting psychiatric disorders in children of first responders who work for them. So children of police officers, children of firefighters. Obviously, you cannot ask workplaces such as the New York City Police Department to measure psychopathology in the children of first responders, etc. It will be time consuming, it will be messy. But workplaces can definitely measure some of the variables that were collected in these data sets. I reported them here. It's 18 variables or 18 features. So variables measuring parental occupation, obviously this can be measured in a workplace. Variable measuring parental occupational exposure, obviously policemen, firefighters could, keep track of the occupational exposure of their first responders. And also they could measure psychopathology, so they could measure if their first responders have major depression, post-traumatic stress, etc. So we build predictive models for children's psychiatric outcomes using only variables measured at the parental level. As you can see, using only 18 variables, the predictive accuracy drops, but it's not bad. A predictive accuracy is considered good, and there's debate, but if it's above 0.7 is usually considered fair, is usually considered a pretty decent predictive accuracy, especially if it's like a first step. If then you do a follow-up to see if in fact somebody has a disorder. So for let's say for initial screening, a predictive model that gives you a predictive performance of something above 0.7 is usually considered fair or decent, let's say. So this is not the case for some outcomes, but for other outcomes, the predictive accuracy using only variables measured at the parental level is pretty good. So for PTSD, for example, you reach a predictive accuracy of 0.77 without feature selection. If you apply feature selection, your performance drops. But even without, even if you don't use feature selection, the predictive performance is pretty good. And you have only 18 variables, so maybe you don't need feature selection. And the same was true for generalized anxiety, for separation anxiety, for agoraphobia, for oppositional defiant disorder. So at least actually for conduct disorder, you have a pretty good predictive accuracy using only variables measured at the parental level. So this is, I think it's a very promising approach. So predictive models, and I think this is the last slide, just a conclusion of predictive modeling. Predictive models for children's psychiatric outcomes with potentially clinically useful accuracy, so they have a good predictive performance, can be developed only using variables measured at the parental level with very little cost. And this is important for the real world practical implementations of the findings on a wide scale. Remember what I said before, if you need brain imaging, if you need genetics, if you need all sort of data to predict an outcome, it might be important to understand from a biological point of view what happens to develop like a drug or something like that. But in terms of prediction at a wide scale, you're not in the best situation. So this is probably because if more knowledge on the prediction of children's psychiatric outcomes from parental occupational exposure and parental psychopathology will be available in the future, then you can fine-tune your risk models according to the context. So you can have specific risk models for police officers, for firefighters, or for police officers, or for firefighters in Israel versus New York, and the predictive models can become more and more accurate. And these models could then be used in real-world settings, such as workplaces characterized by high level of parental occupational exposure, again, police and fire departments, to identify, this is important, to identify using all information collected at the parental level, children that are potentially at risk. So in practice, what could happen? First responder could self-report relevant predictive measures such as occupational exposure and psychiatric symptoms on a regular basis, and then the predictive algorithm based on machine learning would estimate the associated risk for psychiatric outcomes in their children. And then again, this information could then be used to determine whether a more in-depth assessment is warranted. For example, with a mental health professional, or asking children or interviewing children directly to know if in fact, understand if in fact the child has a psychiatric disorder or not. If a child has a psychiatric disorder, then you can use the mechanism that were identified by the causal structure discovery analysis to help guide intervention. So this is why causal structure discovery analysis and predictive modeling are sort of like synergic. You can use predictive model to predict, to understand who has a psychiatric disorder or who is at risk of psychiatric disorders, and then you use your finding from your causal structure discovery analysis to understand how to best help this person, to understand on which variables you could intervene to help this person. And finally, the implementation of a decision support pipeline could be implemented, could be developed to automatically provide recommendations for children of individuals routinely experiencing high levels of occupational exposure. I think that's it. This is some references. I think the slides will be available. So in case you want to do some further readings on some of the things I talk about. Let's see. Thank you very much for your attention.
Thank you so much, Dr. Geronazzo. I'm sorry. Thank you so much, Dr. Geronazzo-Alman.
You're welcome.
It was a wonderful presentation, and I'm pretty sure our attendees have enjoyed it. I'm going to open the floor for questions. We don't have a lot of time. If you have any questions, you can either unmute yourself and ask your question, or you can type it in the chat. And if any one of my in-person attendees have any questions, please raise your hand. I'll bring the mic over to you. It looks like nobody asked any questions so far. Does anybody have any questions? You can unmute yourself and ask a question. And also, Dr. Geronazzo-Alman has put his email in the chat. And if you have any questions about his presentation or anything related to his work, you can always email him over there. Thank you so much, everyone, my in-person attendees and my Zoom attendees, and my wonderful presenter. Thank you so much for your time.
Thank you.
I know everybody have a busy schedule. Thank you so much for making some time for us.
Of course.
Thank you.